Hi there. So we ran out of time a little bit for EMS Grand Rounds this month, and that was mostly a technical issue, and also because I apparently can't stop talking. But I wanted to go ahead and get this part out so that we could give the credit on the stuff that we said we were going to give the credit for. I will be available via Messenger essentially to answer all your questions. So essentially, I am a live instructor for whatever that means for you in terms of what kind of credit you need. I'll be available from about 2 o'clock on the 24th until about 8 o'clock on the 25th, just because I can't kind of be there all the time. But if you send me a question, I will do my best to answer it in the same way as we did the chat function on this thing here. So, sounds good to me if it sounds good to you. So, let's get started and let's talk about a new topic. This one I want to talk about some CPR stuff, and probably not the CPR stuff like the pushies and the squeezies and the blowies and that kind of thing. What I want to talk about is what happens when you don't have to do that anymore, i.e. you've gone out, you've resuscitated Ethel on the floor of her kitchen, and you've done a really good job, and subsequently, because of your great CPR and your great ventilation and your timely defibrillation and plus minus on giving some drugs, you have gotten ROSC. You have a pulse back. Now what do? I will tell you that most people find this very confusing, especially folks that are kind of young or are trainees. Most of us would much rather prefer to do CPR than have to figure out what to do after you get the person back. Because honestly, at that point, it's no longer an algorithm, resuscitation sort of thing that you can just follow and trust that you're doing the quote-unquote best thing for the patient at that point. Now it's just taking care of a really sick person. And that's kind of difficult, and that's why I want to talk about some of this here. But we also don't talk about that very much. You do ACLS, once a year, once every 2 years, something like that, depending on where you're at. But I bet you don't practice post-ROSC care very much. So this is a really critical time in the patient's life, and a time when we really need to be on our game, because this is no longer the algorithmic, it's a dead person that we're pushing on, which I still hate that, but whatever. It's no longer just a dead person we're pushing on their chest. Now it's a live, really sick person that we want to keep alive. Let's talk about that a little bit. This is probably the question that you're going to ask yourself. Let's talk about out-of-hospital cardiac arrest. On a yearly basis in the United States, let's say there's 300,000 out-of-hospital cardiac arrests that EMS is called to attend to. Of those folks, about 25% are going to get ROSC. Of the folks that get ROSC, about 33% are going to survive to discharge, and of the folks that survive to discharge, about 75% of them, of the folks that get discharged home, will have a good neurological outcome. So in total, that ends up at about 6% of the folks that we go out, start doing CPR on. About 6% of those folks in the United States are eventually going to walk out of the hospital able to perform their own ADLs, to clean themselves, dress themselves without a huge major cognitive impairment. So only about 6% quote-unquote success rate if you're looking at that as your outcome. So in between that 300,000 people that we're called for and the 6% that walk out of the hospital, what happens? Well, there's a lot of things that really make a big difference in there. And one of the things that we commonly think about, like from the time that we're called to the scene of the accident or the emergency or wherever it is the resuscitation itself. Now, this is your typical resuscitation. I know we're talking about the field, but I just happen to have this picture. This is the number of people that get called if there's a cardiac arrest resuscitation. This is the hospital in the middle of the night when all these people should be asleep or off doing other things. These are the number of people that attend to a cardiac arrest. That's certainly an important part of how you get a person to survive. But unfortunately, this is more the number of people that show up after you get ROSC on the patient. After you have gotten the cardiac arrest management complete, this is what you get. Mostly an empty room. Hopefully there's a bed and an intern who's still trying to type notes that he didn't get done from the morning already. So here's kind of the example of why this is so important. So when you're called for a cardiac arrest, it's essentially that the wing has fallen off the plane. Something has gone on, and this person is about to die, or they have quote unquote died, which again I still don't think is a great thing. But the wing has fallen off the plane, and now the plane's in mid-flight and it's headed toward the ground, and you got to put the wing back on. Luckily, there's a manual about how to do that, and all of us have to go take training on that manual, every couple of years. Hopefully, you're reviewing it a little bit more than that, but each of us has to go learn something more about that, and it's called ACLS. And that's good because now we're in flight. We got to figure out again how to get this thing back onto the plane itself before it hits the ground. And that's a pretty big deal. We got to get the person back. We got to get a pulse back before their brain 100% dies. Cool. Here's the instructions about how to get that wing back on. Unfortunately, once you get the wing back on, we all tend to breathe this sigh of relief. Here's what then you have to do. And the patient at this point is just kind of gliding along. They're not really stable yet, but here's the next part of what you're going to have to do. This is the complexity of the post-ROSC environment. So you can kind of see my frustration in that we practice this ACLS stuff all the time, but there's really not like advanced ROSC life support. Again, normally in most situations, we are pretty much okay with this part. We can do the pushing, we can do the squeezing, we can do the intubating and the pushing of the drugs and all that kind of stuff. But as soon as the patient gets ROSC, we sort of all turn into this. And if the patient was awake, he would look up and see a bunch of people who probably kind of have an idea of what to do, but maybe not 100%, as well as this random chicken that's chilling out with us. So one of the biggest questions I think that we have to deal with is, where do I start? The whole ACLS thing is algorithmatized pretty well, but where do I actually start taking care of the post-ROSC patient? Well, number one, I'm just going to say, where do you start? You start by making a plan. If you think you're going to get ROSC, which we all should, then you should also have your exit strategy sort of planned out at the same time. So yes, you have to have a plan ahead of time. We ought to have at least an idea of what algorithm or what kind of priorities we're going to have to undertake in the next couple of minutes. Because if we don't undertake those pretty quickly, the patient is going to have less and less chance of survival. One of the other things, after we have thought about and initiated a plan, and I'll get into what that plan needs to have in just a minute, one of the things we have to do is get 360 degrees of access to the patient. And what I really mean by this is, I have said over and over and over again, you should stay in the house and resuscitate the person. Stay in the house, stay on scene, don't think about moving until the patient has a pulse. Well, now the patient's got a pulse, and now all of a sudden that moving becomes a pretty big deal. Now we have to get the person in some place where we can work on them. So that is probably the back of the ambulance, at least to start off with, and eventually it's to the hospital. But we have to be able to get that area around the patient kind of cleared out. It's no longer run as fast as you can and do CPR with whatever, and ventilate and everything with whatever you've got. Now we actually have to get organized and pretend that we're actually in a good situation where we've got 360 degrees of access to the patient. So that's probably going to mean move to the ambulance. After you get 360 degrees of access to the patient and get them off the floor, get them wherever it is that you can work on them, we have to get some kind of access. I, again, have poo-pooed vascular access in CPR patients for a fair amount of time, and I will continue to do so. I think an IO is probably still your best move, but you have to have some kind of access on these folks, because now is the time when things like epi and the vasopressors and maybe the drugs that you might give, now is the time when they have a definite benefit if you're using it correctly. So we have to get access on this guy. Now, of note, an 18 gauge peripheral IV is all you need. It'd be nice if you have two, but you don't have to have deep access on every single post-ROSC patient. One or two peripheral IVs, at least to get you started, will get you there. And don't worry too much that not all these people need like a 14 gauge. They just need something. If you can't get peripheral access rapidly, and of course, yes, an IV in the AC is perfect. It's great. If you can't get that for whatever reason, or can't get it in a timely fashion, there's no reason that, even though we're not doing CPR on the person, there's no reason we can't get a humeral IO on this person. Why waste time screwing around with peripheral vessels when, okay, we just need something that is going to work and that is going to have a high flow rate and it's going to stay open? Humeral IO all the way. Not just good for CPR, good for your post-ROSC patients as well. Now we've got some stuff that we need to start working on. And that's three categories of things. One is what's going to kill him right now, which is mostly the immediate life threats: hypoxia, hypotension, and persistent cardiac dysrhythmia. We need to work on what brought him down, what caused him to go into arrest, because he's probably going to arrest again if we don't mitigate that threat. And then the other thing we've got to do something about, or at least start working on, is what's going to kill him in the next couple of days. And of course, again, there's the antecedent illness that preceded this thing, the MI, the terrible hypoxia, the pneumonia, the sepsis, whatever it was that caused him to arrest to start off with. But then by virtue of him going into arrest, he develops a whole new set of problems as a result of that cardiac arrest. A combination of some brain injury, there's always myocardial dysfunction to some extent, and systemic inflammation that is going to cause him worlds of trouble over the next couple of days. Even if we can get his heart back, even if we can get the initial insult, the cardiac arrest itself, if we can get ROSC, you're not out of the woods, because now you've got this terrible disease that happens after you have a cardiac arrest. To sort of put an analogy to it, if you've read anything about the nuclear bombs that were dropped on Nagasaki and Hiroshima in World War II, there was an initial blast, and it was pretty significant. It was pretty bad. However, it was relatively limited in terms of damage. It blew up a certain amount of area and released some radiation. But after that, a lot of the damage, and perhaps even more so, was that for survivors, of course, without all the radiation part, one of the most immediate threats was actually the fire afterwards. A fire that went on for weeks and weeks and burned a significant portion of the city that was not actually blown up in that initial sphere. There was this terrible fire that went on afterwards that killed a lot of people and, again, caused a lot, essentially comparable amount of damage to the initial blast. And that's the post-arrest syndrome. It's the fire that occurs after the cardiac arrest that we've got to continue to mitigate. And we sometimes forget about that. So what do you do about it? Where do we start with this post-ROSC thing? I've been talking a lot theoretically. Here's where we actually, rubber meets the road, and we figure out what to actually do with these folks. So, number one, we've got to mitigate life threats. In the name of resuscitation, we do a lot of really wacky things. And there's all kinds of stuff that happens to these people once we get our hands on them. Some things are good, some things are bad, some things look funny, and some things are just semi-ridiculous. What we want the person's body to sort of think is that they are relaxed on a beach someplace where it is 78 degrees with low relative humidity and a light breeze with a little bit of sun. We want the person to be absolutely, essentially calm and think that they are at sea level with normal oxygen tension, normal CO2 tension as best we can, and a normal blood pressure and hemodynamics. So one of the things we're going to have to do is, of course, again, just good critical care. We're going to maintain control of the patient's airway, because hypoxia is bad, hypercarbia is also bad. Now, if we're going to do the airway at this point, we've kind of, again, poo-pooed a lot of the cardiac arrest airways and said, well, why don't you just bag them? At some point, you are going to have to switch over to a definitive airway or a semi-definitive airway, or at least an acceptable airway. Realistically, you can't bag a person forever. So at some point, we are going to have to place an airway in the person. And the metric for that is absolutely, at this point, we are going to go for a definitive airway sans hypoxia on the first attempt. Credit to Bill Hinckley for coming up with that one. If you haven't used this metric on all your airways, again, definitive -1A, definitive airway sans hypoxia and hypotension on the first attempt. This is the measure that we should probably be measuring all our airways through. What you really want to avoid is it turning into the goat rodeo that it normally turns into. So everybody is going to get all excited initially about starting some kind of airway. And we've got to get an airway, we've got to get an airway. We don't got to get an airway right now. Again, bagging, okay for the moment. We got to do this right. It's not how fast you get the airway. It's do you do it right and not hurt the patient in the meantime. So not letting that happen is a big part of it. In order to do that, we're going to have to optimize everything we can. So start off with optimized positioning. We're going to get the patient in a good spot. We're going to optimize oxygenation. We're going to optimize all our chances of success because, again, definitive airway on the first attempt without hypoxia, that's the marker. And if you miss it on the first attempt, okay, whatever, but each attempt is going to be harder and carry with it more risk. So let's talk about positioning real quick. If you haven't seen what the actual sniffing position is, folks kind of think like, oh, put them in the sniffing position. Everybody leans their head back or maybe dangles the patient's head off the back of the bed. That is absolutely not the sniffing position. Sniffing position is the patient leaning forward. Head is actually translated forward a little bit until the ear is even with the sternal notch, which is going to look something more like that in most people than it is like that. So, in order to make that happen on most of us, you're going to have to do some degree of ramping or elevation of the head itself. If you notice, this gent's ear is now is now in line with his sternal notch, and both are parallel to the ground. And he's not that big a guy. He's a muscular guy. He's not like super obese, but you did have to ramp up the back of his head quite a bit. We're going to pre-oxygenate all these folks. Again, once you have gotten ROSC, it is important to move quickly and expeditiously, but the more that you kind of rush to get this thing done, the worse off things are going to be. So take time to pre-oxygenate the patient as best you can. If you can't pre-oxygenate them, fine, okay, you're forced to act, but take time to pre-oxygenate the person well. And then when you make your attempt, make it count on the first time. So this guy in the right lower corner has a nasal cannula in place, and he is getting oxygen at essentially the flush rate, as high as you can turn that regulator up. This is apneic oxygenation. The idea being that if you put a nasal cannula on somebody, don't turn it to 6, don't turn it to 15, just keep turning it until it's blowing air as oxygen as much as it possibly can. That will instill some oxygen into the lungs themselves. They will passively oxygenate. They won't exchange a lot of CO2, but you will at least oxygenate the person better. And with this, if the person has relatively normal lungs and normal metabolic function, you can get the SAT to stay above 94 for 5-6 minutes. Again, their CO2 is going to climb through the roof, but this will give you a time when you can at least avoid hypoxia, which is a big deal in these post-ROSC patients. Every single tube, everything you put in the patient's face, any bag that you put on the patient, any eye gel you put in the patient, that has to have a waveform end-tidal CO2 monitor on it, and the tube is not in the right spot until you see it on there. And as an example of that, quote unquote, I saw the tube go through the cords. How would you rate the view that we've gotten on each side? You may say, oh, well, they're both a grade 1-ish view. I can see the hole, I can see the cords, I see the retinoids, I see everything. You say both is a grade 1 view. Well, not really. The one on the right, maybe. The one on the left is in the esophagus. It sure looks like a trachea, but it is actually not. It is the esophagus. It's just being held open because the laryngoscope blade's too deep. So even somebody saying, I saw the tube pass through the cords, is not sufficient to say the tube is in the right spot. Until you get end-tidal CO2 monitoring on this person, the tube is not in the right spot. And it is incumbent upon you to prove that that is the case with waveform end-tidal CO2 monitoring. All right, so we've controlled the airway. Now we need to work on breathing. And breathing, we sort of, again, kick to the side a lot of times and just say, well, squeeze this bag, I'm going to give him oxygen. It's a lot more complicated than that. There's actually some pretty important goals that we'll have to meet in here. It's important to note that we have to be very careful around these lungs. Every positive pressure breath that this patient gets, every time that you squeeze the bag or the ventilator gives a breath, we injure the lungs a little bit, potentially. And so in going back to our thought that the goal is to make the patient think that he is on the beach someplace at sea level breathing normal amounts of oxygen, we want to maintain a very aggressive lung protective strategy, which we'll get into in just a second. Now, honestly, the best way to make all this happen is with a ventilator. And if you don't have a ventilator for your transports or for your post-ROSC patients, I think you should think about getting one, because I think this is all too complicated for us to be able to do. It's too complicated for me to really be able to do and do the rest of the stuff that I want to do with the patient in the post-ROSC kind of phase. And I think it's probably too complex for most of our pre-hospital providers to do the same thing, especially given that you don't have as many people. You don't have the 30 people lined up outside the door like we have in the ER. So I think we're not good enough for it in the hospital. I think we need it outside the hospital as well, which is not a dig at anybody. But put this on the machine, and then let it go. So we're going to start with a tidal volume between 6 and 8 mLs per kilogram of ideal body weight, which is going to be a tidal volume. If you had to pick something, just say 450. That's probably reasonable in a lot of people unless they're super tall or super short. 6 to 8 mLs per kilogram ideal body weight. We're going to set that tidal volume and we're going to leave it be at that point because we don't mess with tidal volume unless you absolutely have to as part of our lung protective strategy. Again, I'd see my ventilator talk in order to learn a little bit more about why. Set the respiratory rate somewhere, I'm going to go for 15. Start on the upper end, start at 15 breaths per minute. And then we'll titrate that up or down in order to maintain an end tidal CO2 of 35 or thereabouts. Maybe 30 to 35 is my preference to get started until we get things sorted out again. I'm going to set the PEEP at 5, and even if I just have a bag, I am going to set the PEEP valve on for pretty much every patient I see. And I'm going to initially set the FiO2 at 100% and then titrate that down rapidly to maintain an oxygen saturation of 94. And by the way, if the SAT is 94, great. I am totally cool with that. I am no happier with the SAT of 99 than I am with 94. Keep it somewhere in between there. 94 is plenty of oxygen for folks. And again, hyperoxia, probably just as bad for outcomes as hypoxia. By the way, I'm going to start my FiO2 at 100 and then rapidly titrate it down once things are stable. Once I get to 40% FiO2 or 60% FiO2, if I notice that he becomes hypoxic, less than 94, I am not going to reach back over and dial up the FiO2 again. That's not a solid move. What I would probably do is increase the PEEP at that point. Let's turn the PEEP from 5 to 7 or maybe even 5 to 10 at that point before I reach for the FiO2 knob again. There are some PEEP tables that are out there that we should follow that are going to make this calculation a lot easier. But resist the temptation when you see the patient becoming hypoxic to turn the FiO2 up a lot without changing the PEEP first, because that's the thing that will really improve oxygenation in a much safer way. Don't forget, too, that at some point these guys are going to wake up, and if you did a really good job with your CPR, one of the first things that you may see them do is immediately wake up and reach for that tube that you've now got in their throat, because that's their main source of stimulus. So these guys should be, they should have some level of sedation ready to go, but they also need some degree of restraint, and watch out for that tube because it's probably going to be the first thing that somebody reaches for. Keep in mind that when I said everybody needs probably some degree of sedation, rocuronium is not a sedative. It is not okay to just paralyze these people, although you'll see folks that have access to it do it. That's the wrong move in almost any circumstance. And I've yet to really see one where I thought it was a truly warranted idea to just give somebody paralytics without a bunch more sedation going on with it. There are a number of options that you can use for sedation. If you're in the back of the ambulance, give them a slug of midazolam. Give them some fentanyl with it if possible, because the two will work better and you won't have to use as much of either one. But for Pete's sake, if the guy starts to move around a little bit, good, but also his mental status doesn't matter for you that much right now. All you need to really do is get the patient to the hospital to start off with. So give him 5 of Versed. It'll wear off within about a half an hour before anybody should be ready to make any kind of decision when he gets to the hospital. Give him a little slug of Versed, put some fentanyl on top of it, like 100 of fentanyl, 200 of fentanyl. It doesn't matter all that much because all the bad stuff that happens with either Versed or fentanyl, you have basically fixed via the tube in his throat or the King Airway or the eye gel in his mouth. So go ahead and give these guys some pain medicine and some sedation. If you have ketamine, that works equally just as well. You give them a little slug of ketamine, say 1 milligram per kilogram. Give that every 15 minutes or so. It'll wear off in about 15-20 minutes. So even if there was some question about his mental status before, now once you just give him, like I said, 15-20 minutes, by the time he gets transferred over to the hospital bed and all the monitors attached to him again, he'll be all set. You may be interested in propofol because theoretically you can turn it on and off pretty easily, and that's true, and it will put people down sometimes. But realistically, I don't see a great reason to use it in the field to start off with. Oh, so we can get his mental status exam. Well, again, there's a certain amount of things that we're going to do in the ER that are almost independent, realistically, fairly independent of what his mental status exam is. And that's probably going to take at least a half an hour to get sorted out. So I would not crush up a bunch of Xanax and inject it in his IV so that he's sedated for hours and hours. But I don't know that propofol is really the best kind of move. It also doesn't do anything about pain. So if you're going to give him propofol, make sure you give him some fentanyl as well. Otherwise, you'll be turning up the propofol until your fingers fall off. And when really all he needed was 100 of fentanyl for his pain, and then the propofol would work a lot better. Now, one of the other things we're going to need to do after we've secured, well, not so much after, but at the same time, contemporaneously, as we've secured his airway and maintained his breathing to maintain the targets that we just talked about, we're going to want to maintain perfusion as well. So of all the stuff we've looked at on the monitor, we've looked at end tidal, we've looked at SpO2, now let's look at the actual blood pressure. And even more so than the blood pressure, is he getting perfusion to his organs after this cardiac arrest? So our targets, and we should be, again, fairly aggressive with this, is to maintain a mean arterial pressure between 65 and 70. Why 65? Because it's at 65 that our organs, specifically our brain, lose the ability to auto-regulate. So if your blood pressure is high, your brain can limit blood flow to the area so that you don't overpressurize anything. Likewise, if your blood pressure drifts down low, your brain has means to augment perfusion to it. Once you get below 65, though, the brain has no more way to increase blood flow, and so it starts to get hypoperfused, or can start to get hypoperfused, I guess I should say. But our goals are typically going to be a map of 65 for that reason, so that we maintain plenty of juice for the brain to be able to use and extract oxygen and glucose from, and a systolic blood pressure of greater than 90, which is, they'll kind of run together. So there are several ways to do that. One could be with inotropes, something like dobutamine or milrinone, depending on what their cardiac function is. Most of the time we're going to reach for something that is more just a straight pressor in these folks. So we'll talk about that in just a second. And then maybe a combination of IV fluid in there as well. Now, most of these folks were not hypovolemic before they went into their cardiac arrest, and so they don't need tons of fluid afterwards. In fact, tons of fluid could potentially be dangerous for them because you're injecting a whole bunch of fluid into a failing heart. However, to optimize preload in most of these guys, a starting dose of 500 cc bolus to see if that augments their blood pressure a little bit is pretty well tolerated and probably not going to cause any problem in anybody. So you can give some fluid, but don't use fluid to be sort of the primary thing as your pressor. Don't think that, well, he's gotten 3 liters of fluid, maybe the fourth one is going to be the one that really tips him over. If he's gotten 3 liters of fluid and he's still hypotensive, you should have probably added on something about 2 liters ago. But a little bit of fluid in most people, a little bit of a fluid challenge to see if it improves their blood pressure is usually a reasonable thing to do. Talk about the drugs themselves. Ideally, if you knew the patient's cardiac function, then you might titrate, or that might change the way that you would give drugs if you had them available. So you might, for instance, give something again like dobutamine if you were able to do an ultrasound and see that the heart, instead of going like this and big squeezes, if the heart's just kind of sitting there and going like that, which most of us can kind of figure out on an ultrasound, then we may want to reach for something more, again, like a pressor, not like a pressor, but something like an inotrope, like, again, dobutamine, maybe even dopamine if they're bradycardic. This might be the time when that's actually a good idea. But however, if we see the heart, making a pretty good contraction, or we think it's making a pretty good contraction, maybe we're going to reach for something more like norepinephrine. So in the emergency department, what we'll usually start people on kind of as first-line pressor for almost everything nowadays is norepinephrine, Levophed. And this is easy for us. We've got pharmacists, we've got nurses, everybody's comfortable using it, everybody kind of is comfortable with the dosing. Unfortunately, we don't have that on a lot of the ambulances, at least in this part of the country, especially our ground ambulance services. I doubt anybody is carrying it, but maybe somebody is. Nonetheless, if you don't have norepinephrine, a probably reasonable choice, rather than opening up the bag of dopamine and kind of futzing around with that thing, probably a more reasonable choice in the post-cardiac arrest patient is a touch of epinephrine, and doing it as the push dose epinephrine. How do you do that? Well, lots of other people have talked about it and describe it better than I'm going to, but really quickly, what you do is take the carpuject of epi that you just would have given for a code, so the 1 milligram per 10 mLs, you take 1 milliliter out of that and dilute it into 9 milliliters of something else. saline, preferably in a syringe. You give that a good shake, and now what you've got is a solution of 10 micrograms per ml of epinephrine. And when the patient is hypotensive, you give them a little squirt, like 1 to 2 mLs of that solution, and then watch their blood pressure go up. They don't go up to the 150 that you would have gotten if you gave them the whole milligram, but it goes from a map of say 58 up to 64. And we're pretty happy with that. If he needs a little bit more, you can give him another 1 to 2 mLs. And this is usually good for about 5-ish minutes before you have to redose. So again, to recap real quick, push dose epi, take your code epi that came in the little glass, glass carp eject. Take 1 ml out of that carp eject. Mix that with 9 mLs of saline, and then give 1 to 2 milliliters of that every 5 minutes or so to maintain a systolic pressure of greater than 90, or a MAP ideally of about 65. So I'm going to go ahead and cut it off there for right now. Airway breathing and circulation, as well as maintaining the person, to his mind, on a sandy beach someplace with low relative humidity and normal oxygen tension. That's sort of the first half of it. That's mitigating the life threats. Now we next time have to talk about how do we mitigate that post-ROSC syndrome. And even though this is something that happens several days down the road, what we do immediately heavily influences that. So we'll talk about that next time, because that's also sort of a big area. In the meantime, Walt Lubbers for EMS Grand Rounds. Thanks for listening.